Over to you. Thank you.
All right. Good evening, everyone, and welcome. I'm Fred Rogers, parent class of 2021 and director of annual giving at Hamilton. You'll pardon me if in that capacity, I just remind you of what's going on at Hamilton tomorrow, October 1st. As you all should be aware, it's Hamilton at Heart Day, when we'll be seeking 3,500 donors to the college. I urge you to consider participating or at least checking us out online at hamilton.edu/heart. End of public service announcement. And now I'm really pleased to introduce my friend, our much honored presenter, Dr. James C. Cobey, class of 1965, whom I've come to know through his active participation in his 5-year reunion committees. In wonderful liberal arts fashion, Jim earned his Hamilton degree in history, specializing in 19th century foreign policy, the Kingdom of Thailand. He went on to receive his medical degree from the Johns Hopkins University, where he subsequently earned a master's degree in public health, focusing on international health. Jim completed his orthopedic residency in 1976 at Yale University. Jim's international experience is both extensive and varied. He has worked with the United Nations Relief and Works Agency, better known perhaps as UNRWA, in the Gaza Strip, assisting with refugee care. Also in Western Nigeria, studying epidemiology, in Northern Haiti, developing public health programs, and in Hong Kong, helping tuberculosis and polio patients. In 1979, as a health delegate for the International Committee of the Red Cross, he coordinated one of the largest refugee camps along the Thai-Cambodia border. Significantly, in 1991, Jim and others conducted the initial epidemiological study of landmines, which led to the creation of the famous ICBL, the International Campaign to Ban Landmines, work for which he shared the 1997 Nobel Peace Prize as a member of the group Physicians for Human Rights, putting him in the same category as our esteemed alumnus Elihu Root, class of 1864, also a Nobel Peace Prize laureate. Jim's volunteer service is extensive, as is the recognition he has earned, including significant honors from the American Red Cross and his graduate alma mater, Johns Hopkins. Jim, as we see from the slide here, is one of the 2 original founders of the G4 Alliance for Surgery, Obstetric, Trauma, and Anesthesia Care. And are you exhausted yet? He has most recently been working back in Gaza. Jim, thank you for carrying the name of Hamilton forward throughout your astonishing career. Let's now hear from you.
Well, thank you. That's quite an introduction, Jay. Okay. I'm going to give you a little background of surgery in developing countries. The G4 Alliance for Surgery, Obstetrics, Trauma, and Anesthesia, and the effects of COVID-19. To start off, I want you to realize that 5 billion people out of 7.5 billion in the world do not have access to safe, affordable surgery. Almost 3/4 of the world cannot get surgery, trauma or emergencies or anything. Almost 300,000 women die every year of complications of labor and obstructive labor, usually postpartum hemorrhage. Approximately 28% of the global burden of disease is amenable to surgical intervention, but doesn't get it. Getting the scale of the problem. We look at, everyone talks about HIV, AIDS, TB, malaria. Well, injuries deaths from injuries is much, much greater. Many more people die of lack of medical surgical care than the HIV, AIDS, and malaria. It's a big worldwide problem people forget about. And all goes back partly to the Alma Ata Conference. I'm sure you all remember the Alma Ata Conference of 1978. It's actually started with one of my professors at Hopkins. At Alma Ata, they came up with this concept of health for all by 2000. Health for all by 2000. Primary health care. And Mahler was a general back then, the Secretary General of WHO, said, but you forgot about surgery. They dropped it. They just thought about primary health care. That was the mantra, primary health care. And that changed things. So after that, let's get into, I teach people about what you need to know about surgery. Start with the Lancet Commission. There are 3 journals I recommend every medical student read all their lives: Lancet, New England Journal of Medicine, and Journal of American Medical Association. And the Lancet started this commission on surgery. We had this DCP, disease control priorities, and we started to talk about the surgery district hospitals. These are things I hold up and I give lectures to students. Surgery district of the hospital is a, I'll show you, is a series of monographs put on by WHO. So here are the key messages. 5 out of 7.5 people in the world did not have access to safe, affordable surgery. They don't get it. They die without it or cripple the rest of their lives. In low-income countries, 9 out of 10 cannot get basic surgical care. 9 out of 10. Most people cannot get basic surgical care. 143 million additional surgical procedures are needed in LIMCs to save lives and prevent disabilities. Of 313 million surgical procedures in the world, only 6% take place in the poorest countries, where a third of the population lives. 33 million individuals face catastrophic deaths from expenditures. Say this expenditure, you can't afford it, you can't get it. I was working in a hospital in Congo for a while, just about 6 or 8 years ago. If you came in and couldn't afford it, you were sent home. Go home. Or if you did somehow get the operation, because someone brought some money in to pay for a day in the hospital, if you couldn't pay the bill, you couldn't go home. You were kept in the hospital till some family could bring you, pay the bill. So hospitals in Congo and many countries are really debtor's prison. You can't leave the hospital if you haven't paid the bill. And I've seen this in many countries in Africa, Sierra Leone and Liberia. They need the money, and you can't pay the bill, and you're not going to get any treatment. It's frightening. So investing in surgical services is affordable and promotes economic growth. Number of surgeries needed is about 100,000 per 100,000 is based on data from New Zealand. We use that, the Lancet Commission used that as a standard, how much surgery is needed. But basically, we came up with the concept that surgery is indivisible, indispensable part of universal healthcare. You got to have surgery involved in it. This is take the mind change. And we went to the UN and WHO said, got to rethink things. We need surgery as part of everything, a part of any care. Otherwise, you're not getting the basic treatment you need. So let's talk about this. Goals by 2030. So we started this G4 Foundation back 2014. 2 of us together at Hopkins dreamed it up. We need to get people involved. Then we get the Lancet Commission going. So here's our goal. By 2030, 2-hour access to a hospital that can perform bellwether procedures. What's a bellwether procedure? I'll explain to you in a minute. Simple procedures. To do that, you need not just more hospitals, a doctor, you need roads, you need transportations, and blood banks. You need 0.2 surgical anesthesia obstetrics, SAOs going, per 1,000. Most developed countries have 20 SAOs per 1,000. But in Africa, it's only 0.2. Not many doctors around. You need 50 procedures per 1,000. And more important, you need tracking the post-op morbidity and also tracking of the costs. You need protection of out-of-cost payments. People go to the hospital afraid to go there if they can't pay. They'll be stuck basically in the prison of the hospital. So these bellwether procedures, every hospital should have them, every district hospital. C-sections, laparotomies for acute abdomens, and care of open fractures. Those are 3 things that the Lancet Commission said every district hospital should have. So first you need blood. The average donation rate of blood in developing countries is 2.8 per 1,000 people. What? In our country, it's 36.4 per 1,000 people, which isn't much because only 5% of people in the United States donate blood. 5% of who can give. Many people can't give for other reasons, but 5% of people can give, only 5% donate blood. All of you tomorrow go to the Red Cross and donate a unit of blood, please. We need it desperately. postpartum hemorrhage in West Africa takes about 3 units. So people die. There's no blood, you could die. When I was in Haiti, I started a walking blood bank. This is 50-some years ago, where you take everybody in the village, you type them, because you don't have a storage facility. You need blood, you go out and get them, bring them in and get a unit of blood from them. But people often aren't tested for malaria or hepatitis C as HIV, because they're desperate for blood. So these 40 40 procedures we talk about people need in simple countries. It's hard to read the slide maybe, but every district hospital, small district hospitals should be able to do this. Dental extractions, dental abscesses, cesarean sections. And I've done an awful lot of C-sections in my life when I'm traveling abroad. Ectopic pregnancies, vasectomies, simple abdominal procedures, as well as suturing wounds, irrigating wounds, and skin grafting. And people say, you're an orthopedic surgeon. I always tell medical students, remember you're a person first, then you're a physician, then you're a surgeon, then you're a specialist. You always start as a doctor first. So I think any doctor should be able to do these things, because I've done them. I'm old fashioned maybe, but every doctor should be able to do simple surgical procedures and abdominal procedures. So people are afraid to go to the hospital. Why? There's 3 delays. We want to get them in there within 2 hours of the need. They're afraid to go to the hospital. The surgeon, they may just rather sit there and have a baby at home as instructed than die. They're afraid to get there. How do you don't know what's going to happen in the hospital. People die in hospitals. Then you have to get to the hospital. And that means you need a road. Without a road, you can't get there. When I was in Nepal, CARE had given a lot of money for one thing, to develop little bridges between mountains so people could get to clinics in 6 or 8 hours rather than 10 days. So you need to get to the hospital. Then you have to receive care. In many hospitals, I've seen this in India, you get there and they say, oh, no insurance, goodbye. Go to some public hospital. We may have to wait 2 days for care. And this waiting for care is a problem. When I was doing surgery in Ethiopia, you have a presentation in the morning, Monday morning, of all the cases seen in the ER the day before. And they said, we only showed 20, but we have another 40 we're waiting outside till tomorrow. We can only see so many people. So if you're not in line, you're not going to be seen, even if you're open fracture or acute abdomen. So we always talk about what kind of equipment the hospitals need. If any equipment you have must be repairable locally. So many people have stores of equipment needing repairs, they can't do it, can't fix them. I remember one of the best students I ever sent to Nigeria, I guess it was Bangladesh, was a lady from a medical student from Yale. And she got there, and with a screwdriver, she got more equipment fixed quickly. So many pieces are broken and no one knows how to fix them, know how to start. When I was in, last time I was in Tanzania, I had a student from Duke University who went through all the anesthesia machines and fixed them. So knowing how to fix equipment is crucial. Otherwise, things break down. I remember a bunch of oral surgeons came to Nepal to a program we started and brought these fancy, high-tech tools to work on teeth and jaws. They were 3 days and the switch broke. That was it. So you can't repair things locally, they're not any use. So the 10 needs for proficient surgical care, anesthesia care. You need a trained surgical provider. I often had to do my own anesthesia in some countries, usually spinal. So you need trained, and these don't have to be doctors, and preferably not the surgeon. I had to do it. You want someone who can handle anesthesia. And I remember doing a procedure, a hip procedure, teaching them how to do it in Congo. They said, why? I said, can you please take the blood pressure? They say, why? Patient's talking. Please take the blood pressure. Patients do drop. Oh, okay, we'll do it just to keep you happy, but you're a foreigner. We'll take the blood pressure. So you need infrastructure, supplies for surgery, electricity, water, PPE, and basic capabilities to do HIV testing. You need to be sterilized. This is often not effective. You may have two of these sterilizing machines that don't work. You need a blood supply. That's why you have the donations of blood. You need drugs from a WHO list of essential medicines. And this is important to be sure any donation of drugs follows the WHO guidelines. When I was in Cambodia, I had a truckload of donated drugs come in and dropped in my lap, about a whole dump truck full of them. They weren't WHO drugs, they were sample drugs from doctors. So I had to burn them all because they were absolutely useless. You need nurses who can watch things. Nurses are often the second most important person in the operating room. The most important person is the patient. Then you need a nurse to watch. Why? The doctor looks at the abdomen of the knee. The anesthesiologist looks at the airway, but the nurse looks at the entire patient. You need a good nurse to watch what's going on. You need post-operative care available. And just a minute. And you need somebody to watch what's going on and audit it. I'll get this over here. So strengthening surgical plans, that's our goal. So we, G4, work together with WHO to work with surgical plans. What do you mean surgical plans? Well, we want to raise surgical capabilities in 50, 60 countries. They need plans. And means not just we'll make new operating rooms or new doctors, we need a plan. You need to collect data on how many hospitals you have, how many doctors you have. So many countries have no idea how many doctors they have. Many have left and gone to Europe or United States. How many doctors you have? They need a plan, have surgical planning and systems planning. What do you mean systems, healthcare systems? Well, let's talk about patient has a cardiac arrest. You're in the operating room. And you say, call a code. Well, calling a code, hey, code, doesn't help. You have to have people trained where the equipment is, who is available, how to get there. So all these things in a hospital need planning. So one of the things I've tried to work with the last 10 years is accreditation of hospitals. The American College of Surgeons, which started in 1915, in this country, the most important thing is start evaluating hospitals. Many hospitals were horrible back then. Had no planning, had no lights, no electricity. They started crediting hospitals. Are these hospitals safe to operate in? So I'm working with two groups of people, the West African College of Surgeons, who's finally got a system to accredit hospitals, and COSEXA. COSEXA is the College of Surgeons of East, Central, and Southern Africa. These are great groups of great dedicated people. And we're working with them to try to get a system so they can inspect hospitals. So we're getting people involved. Then we went to WHO. Or actually before this, in WHO, when I first started working with them in the 1990s, there was no surgical part of WHO. It had nothing in surgery. No one, it's even in public health, but no surgery. There was a rehabilitation section, and a very nice surgeon who was doing rehabilitation wrote this book, 3 books on surgery at the district level hospital, which is great. Rather than going off to the government hospital or the hospital in the capital city, can district hospitals do simple surgery? They were great. It's well done book, well written. But I felt at this point that when I see something done, it's better than just reading about it. So we developed 7 half-hour videos for WHO to send to district hospitals. So doctors could get out and see how to fix a broken wrist, fix a broken ankle, all these things, rather than just read about it. Initially, I wrote all these up, and the staff said we're too busy unless the staff knew how to handle WHO access. So they sat in a pile in a WHO office about a year or two. Things changed. In the early 2000s, this group called GEAS, Global Initiative for Emergency and Essential Surgical Care, started by Meena Sherian. She's an anesthesiologist from India. And must have been surprised she found my videos, put them on CDs, and I found them in hospitals around the world now. So they're getting around. And then she kept on using I had a tool to study landmine injuries. She used that to develop a tool for hospitals to evaluate their own capabilities for handling surgery. So it was impressive. She did a lot to get this whole thing moving. So we have geese, the WHO, helping surgery. I had to say right now, as we speak, as of today, nothing is happening in WHO for surgery because of COVID. Everyone say, we'll handle it later, Dr. Cobey. But anyway, our philosophy is train, train, train. We look very poorly on groups that fly in and do surgical procedures and leave in a week. And that's done all the time, especially by American NGOs. They'll fly in and do 10 to 20 cases and fly home and feel great about themselves. We help 20 or 30 patients. But they've done nothing for the country. They made themselves feel good, but they haven't changed anything. So back in the mid-'80s, we started something called Health Volunteers Overseas. And HVO only teaches. It never touches to a patient, talks to a patient, does anything unless somebody else to teach. Never do procedures that can't be done until the trainer, after the trainer leaves. And never bring equipment that can't be repaired locally. So again, we have examples of all these people flying in, doing cases, leaving. And Operation Smile was like that for a while. Operation Smile would fly in, fix cleft palates and fly out. They've changed. Now they train. They train completely, and they always have people to train. But this flying in and doing things doesn't do anything for the world. I remember who was a Republican head of the Senate, Dr. Fritz, wasn't it? Who was it? Who was head of the Senate?
Yes, Fritz. You're right.
And he was a cardiac surgeon. He'd go over here, fly abroad, and do 6 or 7 heart cases and come home. And he wanted to start this whole program. I sat and talked to his staff. This is not what you do. I appreciate Dr. Fritz very much, but this is how you do something. And he changed his philosophy and tried to get new bills through Congress. Never happened. So this is what you're doing in these countries. This is a nice operating room. This is one on the left in Congo and one on the left is in Bangladesh. You don't wear a shirt because it's too hot. The air conditioner is not working. You're using open drop ether. Now, I'm probably one of the few doctors in the United States who know how to do ether anesthesia. Most don't know that anymore. But it works. It makes you sick, but at least it's pretty safe. But if you're lucky you have electricity, because often you don't. Often there are chickens walking under the operating table. But high tech, I go to, here we are in Malawi. Now Malawi they can really do things. They've got plaster, because in many countries you have to make up your own plaster. You buy a bag of it and you mix it up and pour it in gauze. And they were doing great. I was really impressed with what was doing in Malawi. But Malawi has a whole different system. They have non-physician clinicians, or medical officers they're called. This is a practical issue. It takes a long time to train a surgeon. In our country, 4 years of medical school after undergraduate. In most European countries, it's a 6-year for the whole thing. But then 2 or 3 or 4 or 5 years of training. This takes time. In Malawi, they have a program, clinical officers. They take 3 years of training after high school. They have to be the upper levels of high school, not just they're actually the better students. They take 3 years and they do general medicine and surgery. You say you can't train a doctor in 3 years after high school and then expect him to do surgery. Well, my grandfather graduated from the University of Maryland in 1895, the age of 21, after a 2-year course at University of Maryland. He went to Frostburg, Maryland, and did general practice and general surgery for the next 40 years. And it was very good. In fact, my father often gave me anesthesia for his patients. So you can train somebody to do surgery if they know when to refer. Otherwise, it's a problem. And these, in Malawi, you have 4 referral hospitals, but other 25 hospitals otherwise. And these hospitals, district hospitals, do great surgery. And more important, these physicians, clinicians stay in the district. They're committed to their own people. They don't say, oh, they can fly to United States now, fly to Europe and be a doctor there. They can only stay in the country, and they're committed to the country. And they're much cheaper to train than a full surgeon. So I say, in 2013, we started this raise funds for geese, and the G4 started to do that. And then 2015, finally, we got through the WHO meeting resolution 6815, which meant Surgery is part of primary health care. So our plan was to advocate for setting up networks to avoid duplication of efforts and training, implement policies, surgical plans, mobilize resources, raise money. That's what we're doing right now. An hour ago, I was on the phone raising money, and we're also working for AID, and start maybe a global fund for surgery someday. If you go for AIDS and everything else, let's start one for surgery. So I say that when you're working out in the middle of nowhere, you've got to watch what you're doing. And in Malawi, we had a lot of crocodile injuries, horrible crocodile injuries. So that's what is life being out in the middle of small countries teaching. But what's the effects of COVID-19? It stopped elective surgery, stopped hernias, cleft palate, club feet, and almost everything else, as in the US it has abroad. Most countries have to keep 30% of their beds empty for COVID patients. So people aren't getting treated. No respirators. In most of these countries, no respirators. When I talked to people in Gaza last week, they had 3 for the whole 2 million people. That's all they had. So most people will die if they get it badly. And the biggest problem, healthcare professors are being attacked for 2 reasons. First, many people feel that the doctors and hospitals spread the COVID. So we want to get rid of the doctors. Or they go to the hospital and say, take care of my patient, not that one, or else I'll kill you. But hospital professionals are being attacked continually. And also, practically from wars. Now, there's something called the Geneva Conventions, which I teach all the time for the Red Cross. You don't attack hospitals and medical staff. But in fact, it's done all the time. Syria, Yemen, Sudan, and many other hospitals are bombed. I've got friends in hospitals that are bombed out, mainly in Yemen and Syria, mainly. Contrary to Geneva Conventions, the warring parties are attacking healthcare facilities to make people feel there is no hope, give up. They're attacking things they said they wouldn't have. It's a sign of Geneva Conventions. Healthcare staff is targeted by not removing patients from machines. So I want you to also look up Physicians for Human Rights, PHR, on the web, and also ICRC. Look at Geneva Conventions. Everybody should know the Geneva Conventions. I know Bush II administration had never read them before he got the job, but I teach in medical schools the basic things we all need to know. But Physicians for Human Rights goes where and looks at problems and comes out and helps solve them. And I've worked with them on many issues. So, Alma Ata 1978 thing, health for all by 2000, primary health care. We want NGOs to talk about surgery because care dropped it. So that's my major issue. Any discussion or questions? Only 4 or 5 of you on the phone, but go ahead. So I go back to Fred.
Well, I do have a question for you, Jim. I wanted to wait to see if anyone else wanted to jump in, but hearing none, let me ask. I want to call you back to Cambodia, Jim, a country that's dear to me. Having visited recently with my Hamilton daughter, and landmines there. I'm assuming that when you talk about shortage of surgical procedures, that's particularly critical in countries like Cambodia, where they have a high incidence of people who are injured by exploding landmines. Is that correct? Right. What's the situation there?
Well, that's a problem. Not as bad as it was 30 years ago. At least we taught surgeons there how to clean a wound, wash the wound out and close it, or leave it open and let it heal by itself. This is crucial because one interesting problem I had when I came back from that and started talking about it, excuse my grandchildren running around, the American College Academy of Orthopedic Surgeons wanted to get an airplane and fly doctors over to Cambodia to handle landmines. What? This is crazy. They really want to do this. Oh, they're getting from a church, one of the big churches in Texas, evangelical church. They could give us their plane, go buy from them, and fly doctors over to treat landmines. No, it's an absolute waste of money and waste of time. You treat people, teach people how to treat them. You don't fly in your stiff system. But anyway, they're handling them now. They're less than it used to be, that's for sure. COVID is the real problem to worry about. People can't get treated.
Jim, what is the effect of COVID on your international work?
I can't travel. I can't travel.
You know, has the group really been shut down as a result?
Well, no, the G4 system is going. We're raising money. I've talked to congressmen, senators, trying to get money in the USAID for surgery. They've never done it before. I've been in contact with people. I talk to people in Gaza all the time. And they told me that 30% of the beds are kept empty for COVID patients. And COVID's going up in Gaza dramatically in the last 10 days, 2 weeks. It was sort of isolated, but now it's getting a problem. But our volunteers can't travel. No, we can just work by raising money for it, because it's really not our job to send doctors abroad to teach. That's important, but to help raise money for these countries to do their own planning and training programs. Okay. So that's what I'm still working on that through G4 and WHO. If there is a WHO right now, gee, it's a problem. Hope that'll change in another 2 months. But I mean, we all need a WHO in spite of what our great president says.
Do you have to work through the governments in those countries, or are you free to get in and out on your own?
We can always get, first of all, most countries require American a license. So you have to have a license. When I flew to Palau, any of you have been to Palau? You know what Palau is? You know Palau? It's a little island 600 miles east of Philippines.
Right.
And I had to fly there to operate on a patient, a Uyghur. And I had a license. I had my American license. I got there. They made up for me a Palau license so I could operate. You have to follow the local rules. I've had people say, no, don't worry about the COVID. No one ever asked. Follow the local rules. And then you want to work with the government. Any program you have is worth a salt, wants to carry on, the government's got to be involved and committed to it. Not just you've done your thing, help one hospital and gone. It's got to be a nationwide thing. Not just build up one hospital as a big super hospital. We want the whole country is involved in surgical training. So I always work with governments if we can. Ministry of Health and Ministry of Education. And the biggest problem is the Ministry of Finance. You need to work all three to get changes in their education system.
And do they provide security for you while you're in the country?
Who is they? I've never thought much about it.
Okay.
I never thought about it. I know in people with MSF, in Sudan, they had security. That's a real problem. But no, I never thought about it. I worked in anywhere I went. I've never thought about it. I just go with other doctors, and it's never an issue.
Good.
Jim, I have another. Oh, go ahead.
Sorry, Fred, sorry.
No, go ahead. Go ahead, please.
I'm really curious because I am really interested in maternal and child health. And I'm curious what you're seeing, or if you have any knowledge of like what's happening with kind of the obstetrics piece of it, because it seems like even prior to this, women were more likely to stay home than undergo, because obviously a C-section is an extremely risky surgery. And then with COVID and everything and people's fears of going to the hospital, like you mentioned before this, are you seeing issues with maternal health at this point?
This is the real problem of training. You've got to get physicians trained who can do C-sections. One of the common causes of fistula is not just a tear from no proper obstetrics, it's a C-section done badly. So you need people trained to do C-section. And don't have to be surgeons. We had general practices doing them when I was in Congo, and any doctor should be able to do C-sections. That's not trained in this country, but I work abroad. That's why I teach everybody to do C-sections. So you need people who can do simple C-sections, and you need all right. You need blood and you need anesthesia. In Afghanistan, I have a good friend doing a study there. He found the mortality rate of C-sections in a couple of hospitals was 25%. 25% of the women coming in for emergency C-section died because they didn't get soon enough. People there didn't do enough of them, and they didn't have the sterility. Horrible. So having quality behind this, not a big quality, simple quality, is crucial.
Jim, I had another question. We seem to understand lately that the current administration is less interested in being a bulwark of support and leadership on the international scene generally. Are you feeling that with respect to international health, the United States not having an open hand with respect to funding and other support for the kinds of work that you're doing?
Well, everybody I talk to has my background in this, and tomorrow I'll be talking to Senator Leahy, who I know very well, who's a nationalist. You know, I keep telling people, I guess it's not our president, we're all members of the world. Not just US, we're members of the world. So we all need to work together. And I keep running these people, all members of the world, not just US first, America first. That's our job, we're members of the world. I don't think our president had much liberal arts education. I'm not sure what education he had. But anyway, he didn't have history, that's for sure.
Well, I take seriously your comment, Jim, that as you said, we're all people first and doctors second.
So, well, I mentioned MSF. Do you all know the difference between MSF and ICRC, how they work? You know what ICRC is? I see a shaking head, no?
No.
Well, this is important, very important. Again, you're supposed to be taught Geneva Conventions in school. The Red Cross started in 1863 after a guy named Henri Dunant, Swiss citizens, saw a horrible battle in 1859, the Battle of Solferino. He realized you need systems to take care of people who were injured. They weren't back there. So the Red Cross started, and then the ICRC. The ICRC is the International Committee of the Red Cross. It's neutral, handles everybody who needs care, and doesn't talk about it. They do it and keep their mouth shut. MSF, Médecins Sans Frontières, the Doctors Without Borders, MSF, started during the Biafran War. And these are a lot of French doctors who got upset with the uptight Swiss ICRC. Look at all these horrible things. You must tell the world how bad things are. And so we're going to start our own thing, MSF, Médecins Sans Frontières, and we will treat and tell the world what we see. Well, for many years, the groups didn't talk to each other. When I was in Cambodia with the ICRC, a delegate from the American Red Cross, we didn't talk to MSF. MSF didn't talk to us. But now they know each other very well. They need each other. The difference is ICRC goes in, does a big operation, it's much bigger than you think it is, food, water, everything else, and keeps their mouth shut. Why? So they'll get kicked out of the country. MSF goes in the country and does good work, and more health stuff done by them now than the Red Cross, and then tells the world what they see. They tell the world, like in Sudan, they tell the world all the women being raped, and they were kicked out. And that happens routinely. The reason they were kicked out because they went to Bashir, who's now in power, and Bashir said there cannot be any possible rape in Sudan. Simple. We're a Muslim country, no sex out of marriage, so rape's impossible. And that was being used as a method of war. So MSF gets kicked out and ICRC stays there. Now they both realize they need each other. You need someone to tell the world how bad things are. Someone else can keep carrying the operation on. So they work now people go back and forth, but they have the rules of who they're working with. And they're actually good friends, but keep separate in the field. My daughter works at MSF many places, and she said, Dad, I'm a really neutral. You're not. No. You got to know how they both work and their rules. So, any other thoughts? If not.
This has been terrific. Thank you so much. It's really wonderful. We have, I just want to introduce you at least virtually to Judy Gray, who's our healthcare, Hamilton Career Network Healthcare Chair. And I'm delighted that she could be with us tonight. And I know she's done some work like you have in developing countries.
And she's on the panel somewhere.
Judy, you have to say hello so you'll pop up and he can see you. I'm not sure she can unmute, but.
Yeah, hang on. Can you hear me?
Yeah.
Here we go.
Thank you for all you've done. I thought you made a lot of great comments about working to not just fly in and fly out. We've done some work with Operation Rainbow, which you probably know is under Operation Smile, but the orthopedic side, but also engaging the local physicians, which seems to be harder than engaging the patients sometimes, you know, to taking an interest, and then learning the culture of, you know, they know where the blood bank is and they know where the autoclave is to sterilize the instruments, but it goes in a circuitous route, sometimes through a market and some other unsterile things. So you're absolutely right about the training. And I think, and I work in public health, so I feel as if there has to be a connection between public health policy, working with community stakeholders and NGOs and clergy and a whole host of groups, but also, and local knowledge, and gaining trust, but also getting the buy-in really early. You know, a trusted physician in the community, policy framework that makes sense, and ongoing. You can't just do it once in a while. So,
HBO is set up so our doctors who train go every year, usually 10 doctors a year, each rotating for a month. So it's a continual training, and everyone knows who's training what and what the curriculum is. It's crucial. This background in public health is interesting. I had trouble getting my residency in orthopedics. I was the first guy at Hopkins to get a MD and MPH at one time. I applied to Hopkins, Columbia, Cornell, and interviewed with them. And I thought I'd get in because I had background in orthopedics. And they called my father. My father was chief of orthopedics at Georgetown. And he called me, God damn it, son. My first name was God damn it. They just turned you down, Columbia, Cornell. I didn't tell you. They called me. You keep your goddamn mouth shut about public health. They don't think you're a doctor. They don't think you're a surgeon. Well, that has changed a lot in the last. Now the head of orthopedics at Hopkins is now involved in international healthcare and training all through Africa. So things have changed a lot, to say the least.
Yeah, so I went to GW for my MPH, and which I know you have a connection to, and through family. But a lot of our professors were from Johns Hopkins, and I think they go back and forth. And I think they really understood the importance of the funding and the framework, as well as the actual care. You know, we had a number of MD, MPHs. And I think that's hard. You know, it's certainly getting harder and harder for folks to train and do it all. You know, it's very complex.
It is, and my wife's upstairs giving a lecture right now in the School of Public Health. Absolutely, it's hard to get it all, but getting that background in public health is crucial to make you think broadly rather than narrowly. That's crucial, I think.
Even about vaccines.
Right.
You know, I'm glad you brought that up, because one of the things we've been grappling with at work today is we don't know what vaccine we're getting. We don't know how we're going to track the multi-vaccine versus the single dose ones. And then the most important thing is the messaging's been so cloudy. Even in our own country, we're seeing everything you just brought up. Trust, you know, steady patient understanding of science, you know, all that stuff you just talked about, we're seeing it in our own country right now. So
hopefully November 4th, things will change.
Well, last night might have been a deal breaker, but we'll see.
You know, I started the Hamlet Conservative Club 50 years ago. I obviously changed a lot, or they've changed a lot anyway.
It's all those women that go there, right?
Yeah.
So to the gal, I did want to say one thing. To the gal who, was it Mackenzie, who, you want to go to general health?
Maybe Carolyn is in public health.
Oh, Carolyn. So, you know, the rate of maternal death and complications in the US is surprisingly unacceptable, I think. And sometimes it's fantastic that we do this work overseas and we think of everybody as our fellow humans, but there's a lot of work to be done right here in the US too. I don't know, Dr. Cobey, what do you think the future of medical missions and medical work overseas is going to be?
First of all, you're right. The mortality rate of women in this country, especially underprivileged women, is too high. It's worse than Africa. It's horrible. And no one knows quite why. Is it because of nutrition, food, blood pressure? No one knows, but it's a real problem. And again, I want people to stop thinking of medical missions overseas.
Right.
Training overseas. You start a long-term program. It's not you flying over, coming back. You go there, start a program, and keep it going. But it's education. It's not a mission.
I think you're right. And sorry about that. But we'd love to get you involved in our health, and all of you that are here in the Health Career Network. We do a book club every couple of months. We just have a new list of books. I have a great co-chair, Lindsay Wong Burns, and she's also a PA locally in Central New York and a Hamilton grad. And we should have these kinds of conversations, and I hope you'll join us. So a little recruiting here. Sorry, Fred. Cross-pollinated. But yeah, it's great that you do all this. Do you anticipate you'll be going overseas again soon?
When COVID changes. Right now, I'm more involved in the politics of getting funds for training programs and fund for the G's to get surgical plans. I don't think you need me. I was in Gaza, say 6 months ago, a year ago, but you don't need me there so much right now as push other people out. I get more people doing this, not just me. So, but I still send equipment to Gaza, and I was a lot of equipment about 6 months ago, but stuff they can reuse over and over and over again. But I probably would not be doing as much. I might be, but right now it's more organizing.
Well, we'd love to have you come talk to our group sometime.
Sure.
So do you think COVID, access to COVID care is still, we still have the same problems with equity and access here. Do you think there's something to be learned from overseas work?
I don't know. I mean, the fact that patients, hospitals are being swamped with patients right now, and patients are lying in the hallways. I've seen that with HIV, but now people lying in the hallways and they're dying, no medical care. This could be a real problem. So access is going to be a real problem. And that's why most hospitals are required to keep 30% of the beds empty for COVID patients. But we'll see. In some areas, this country having troubles right now, real troubles, I gather. Hospitals are overflowing. We'll see.
Yeah, I actually have one more question. You mentioned ventilators, but I think one of the things we had learned was that not everybody, I know there's a shortage in other countries, but I don't know if this is because the South got a different, I know the word isn't strain, but a different type, but we didn't use ventilators as much. We used different positioning because we learned some lessons from New York. Do you think that's going to affect how the developing world?
No question. Steroids right away make a big difference. Big difference. And patients on the abdomen makes a big difference. Which blows my mind. That's a whole different way of doing it, but that's what they're done right now. I've talked to some intensivists at Hopkins. I know very well, and that's how they change things. Getting people on their stomach for up to 24 hours and getting them back over the back on the stomach. It's a whole different thing that we didn't know about. So we're doing much better treating COVID now than we did 6 or 8 months ago.
Well, I'll get your contact information from Sharon and Fred, and we'll
sure, take me down anytime. Okay.
Thank you.
All right. So Fred?
Okay, well, thank you. I'm always available to talk.
Thank you so much.